It is a real pleasure to give the Gary Price Memorial Lecture. Everyone who knew Gary just describes him as being just a very nice guy. It's kind of beholden on me to try to find something in my career or life that is a parallel of Gary's. And I discovered what it was, is that I am and he was, patriotic supporter of our national rugby team. Gary being Welsh and I'm being Scottish. However, Gary's passion was greater than mine. I've never felt the need to have a Scottish emblem tattooed on my backside. So the problem of opioid overdose is an increasing one. Here we can see on the left the increase in opioid deaths over the last 4 years. And this was preceded by a period of decrease, which David Cameron's government claimed was due to the procedures that they'd put in place. But the people on the street tell you it's because the quality of the heroin was so poor. Recently, there's been a big increase in overdose deaths. These are the data for England and Wales. And largely this increase is due to heroin overdose. You can see that in England and Wales, deaths due to methadone or deaths due to prescription opioids, largely tramadol and oxycodone, have stayed the same. And deaths due to fentanyls are pretty low in the United Kingdom at the moment. There was an outbreak in Hull last year, but it's still pretty limited. This is in complete contrast to the situation in the United States, where, again, there's been a massive increase in the deaths due to heroin overdose, but prescription opioids, largely oxycodone in the United States, are still pretty high. But the big thing that's happened recently is this huge increase in deaths due to fentanyls. These are non-pharmaceutical fentanyls. These are illicitly synthesized fentanyl and fentanyl analogs, which are being cut into heroin to try to enhance the effectiveness of the drug. And this is a huge problem in the United States. Opioid overdose deaths are largely due to respiratory depression. And in 1999, White and Irvin produced this figure in a review, which is a seminal piece of work. And they suggested that if you're an inexperienced user just starting out on heroin, then the dose that you need to take to get euphoria is actually quite low. But the dose you need to take to get to overdose is large. And so early on, there's quite a wide safety margin in overdose. But they postulated that tolerance develops markedly to the euphoric effect of opioids, but develops to a lesser extent to respiratory depression. And so that in the experienced user is having to take a large dose now to get the effective the euphoric effect of the drug, and this is pretty close to the level that you'll get for respiratory depression. Now, this theory has been around since 1999, but actually it's never been tested, largely because of the difficulty in developing animal models of tolerance to euphoria. But when we entered this area, we decided that we'd take a simpler approach, and we've been looking at the development of tolerance to the respiratory depressant effects of opioids. But before I go into respiratory depression and effects in whole animals, I want to start at a cellular level and talk about the desensitization of the mu opioid receptor, because we believe that desensitization of the receptor plays a large part in the tolerance that you see to behavioral responses. And this is a figure from a review article where many of the experts in the field came together to try to make some sense of it. Largely, it was impossible to make any sense of it because there are as many kinases thought to be involved in mu receptor desensitization as there are groups that work on the topic. I'm going to focus on two. I'm going to focus on the GRKs, which are thought to phosphorylate the receptor and then allow arrestin to bind, which will give you desensitization and also arrestin signaling. And then I'm going to focus also on the role of protein kinase C. And obviously I'm focusing on these because these are the ones that we've worked on, and these are obviously the ones that are the most important. All right. I'm completely going to ignore ERK and junk, but I have to acknowledge that there is evidence that these might be involved. So our initial studies were done on neurons contained in the brain nucleus, the locus coeruleus. And we chose these because these neurons express only mu-opioid receptors. So our studies weren't going to be contaminated by any other form of opioid receptor. And our approach was to make brain slices of this region to keep them alive in vitro, and to make patch clamp recordings from the neurons in the locus coeruleus. And the mu-opioid receptor is a GI-GO coupled receptor. So when you activate this receptor, then the beta-gamma subunit interacts with the potassium channel to open the channel, and you get an outward current. And this outward current, due to activation of the receptor, gives you a real-time measure of the number of functional receptors that are on the membrane. So to look at desensitization of the receptor, what we did is we chose to use receptor saturating concentrations of either DAMGO, an opioid peptide, or of morphine. And what you can see here is that when you apply the DAMGO, you get the opening of the potassium channel, an outward current, but as the drug is applied and for a prolonged period of time, then the receptors desensitize and the response declines. We then use this GRK inhibitor, a novel GRK inhibitor called compound 101. And if you pre-treat the slice with compound 101 and apply the same concentration of DAMGO, then you don't see any, or you see much less desensitization of the current. So this would imply that DAMGO is inducing desensitization through a GRK and arrestin-dependent mechanism. And you can see down here that if we look at serine 375 on the C-terminal tail of the mu-opioid receptor, that DAMGO induces a profound phosphorylation of this, and this phosphorylation is abolished if you have the GRK inhibitor present. So for DAMGO, it looks like GRK. For morphine, when you apply it to the neurons, you see very little rapid desensitization unless you up the level of protein kinase C activity in the neuron, either in this slide with PMA, or we've also used oxytremerin M to activate GQ-coupled muscarinic receptors. And what we're showing here in this graph is just the decay of the morphine current, which would be similar to the decay here. So morphine does induce desensitization, and here you can see that it's absent when we make the slice from an animal that has had protein kinase C alpha knocked out. So this would imply that the desensitization induced by morphine requires PKC activity, whereas the desensitization induced by DAMGO is GRK. And so Chris Bailey, Eamon Kelly, and I, in the late 2007, produced a review where we suggested that the mechanism of the mu-opioid receptor desensitization is agonist dependent. Our initial studies looking at DAMGO and morphine are just what I showed you in the previous slide. Now, Jamie McPherson was a PhD student in the lab, and in collaboration with Liz Rosethorn and Steve Charlton at Novartis, we sent Jamie down there because they had robots that he could study a wide range of opioid agonists. And what he looked at was the efficacy of these agonists to stimulate GTP gamma S binding, so this is activation of the G protein. And he also looked at the efficacy of these ligands to induce GRK phosphorylation of the receptor and then arrestin translocation to the receptor. And so you can see that there's a range of drugs with different efficacies. But I want just to draw your attention here to these drugs. These are DAMGO, metenkephalin, and methadone. And these are high-efficacy agonists that are both high efficacy in the G protein assay, but also high efficacy in the arrestin assay. Down here, circled in brown, are morphine and oxycodone. So morphine has relatively low efficacy at the mu-opioid receptor. I always find that clinicians kind of balk at that a little bit. They've got enough efficacy to kill people. All right? But in a pharmacological term, morphine and oxycodone have relatively low efficacy at the mu-opioid receptor. And our theory is that agents with low efficacy, then the desensitization will be primarily through a PKC-dependent mechanism, and for agents with high efficacy, then the desensitization will be largely through a GRK-dependent mechanism. There might be a little bit of PKC for something like methadone. We're not trying to say that it's an absolute PKC or GRK. It could be just different proportions. So we think that for the desensitization of the receptor, that there are different mechanisms for different agonists. We then decided to look at a behavioral response, and we looked at respiration in the mouse. And this just shows our simple respiration monitoring system. The mice are in the dark phase, they're freely moving, and we monitor their respiration. And we allow them to either breathe air or air plus 5% CO2, because this presence of a low amount of CO2 potentiates the opioid depression of respiration in the mouse. The approach that we take is that we treat the animals, we would say chronically. In our hands, chronic is 6 days, but we'll just use the term chronically. We treat the animals for 6 days with morphine. In this experiment, we implanted a morphine pellet subcutaneously, but in subsequent experiments, we've used osmotic mini pumps to deliver different opioids. But the data are the same with both approaches. And what we do is we treat the animals, we leave the treatment device in the animal, so this is still there, and then on day 6, we challenge the animals with a single dose of morphine, 10 milligrams per kilogram IP. Now, in an animal that hasn't been treated with morphine, a naive animal, then morphine 10 mg per kg produces respiratory depression. But in an animal that's been treated for 6 days with morphine, then injection of morphine, you see very little depression of respiration. So in our terms, that this has induced tolerance to the respiratory depressant effects of morphine. To show this better, and so we can get better comparisons, what we do is we take these data and we transfer them into the area under the curve. So what you have here is just the area under this curve shown in this column, and then the area under this curve is shown here. And you can see that there's been a marked reduction in the respiratory depressant effect when the animals have been chronically treated. We then did the same experiment, but 30 minutes before the morphine in challenge dose, we gave the animals calfostin C. We chose calfostin C as our protein kinase C inhibitor because it penetrates the blood-brain barrier. There are better protein kinase C antagonists, but we didn't really want to be putting them in ICV. We were giving it IP. And what you can see here is that in animals that have had a saline pump, when you give them morphine, then you get respiratory depression. Calfostin C doesn't change that very much, but in animals that have had a morphine pump for 6 days, then you see the tolerance. And if you just inject calfostin C just before the challenge, this tolerance is reversed. So we believe that protein kinase C is involved not only in the desensitization of the receptor, but also in the tolerance that we can observe to respiratory depression. In contrast, if we treat the animals with a pump-releasing methadone or a pump-releasing buprenorphine, and then do the morphine challenge, then methadone produces tolerance, so the response has gone down, and buprenorphine produces protection too, so the morphine doesn't do very much. then when you give calfostin C has very little effect, and actually, according to, it's not statistically significant, so that the protein kinase C inhibitor doesn't reverse significantly the tolerance induced by methadone. Buprenorphine is a little bit difficult to describe because you can't say that buprenorphine has induced tolerance, because buprenorphine is a weak partial agonist that slowly dissociates from the receptor. So this could simply be prolonged antagonism due to the buprenorphine that we have here, rather than the induction of tolerance. So we talk about buprenorphine protection. And if it's just antagonism, it comes as very little surprise then that the effect of buprenorphine would be reversed by calfostin C. Now, David Nutt, several years ago, I was trying to produce an issue of the current opinion in pharmacology on drug abuse and various aspects of it. And David said, you've got to start addressing polydrug abuse, because heroin users don't simply take one drug, they usually take many drugs. And this is an under-researched area. And so it sparked in me the idea that we too should be looking at polydrug abuse. And now, heroin addicts frequently take other drugs, and these include alcohol, benzodiazepines, cocaine, and most recently, pregabalin or gabapentin. And we wondered whether or not these drugs that they take, in addition to the heroin, do they contribute to overdose deaths by changing the level of respiratory depression? So we started off looking at alcohol. Now, the National Treatment Agency issued a very long report in 2007. Looked at an enormous amount of data, and they showed that when ethanol was present at death, in the toxicology report, then the morphine levels were usually 20 to 50% lower than in deaths where there was no alcohol present. Here you can see from a study by Rutenberg a number of years ago, this is the concentration of ethanol in the blood after death, and this is the concentration of morphine in the blood. And you can see that actually there's an inverse relationship. When there's a lot of ethanol in the blood, the levels of morphine, the metabolite of heroin, are quite low. Whereas when there's little ethanol in the blood, then the amounts of morphine are quite high. And this suggests that concurrent alcohol use lowers the lethal heroin overdose. The fact that this relationship is inverse, that is, when the more alcohol, the less heroin, sort of debunks the idea that heroin users just get drunk and make a mistake and inject too much heroin. If that was the case, then the correlation should go this way. We also have to consider these subjects here who all died with both low morphine levels and low ethanol. And this is the levels of these drugs are not high. This is the alcohol driving limit in England at the moment. So we have to find some explanation for why people are dying with low morphine and low ethanol in their blood. So there are several possible explanations. The common wisdom at the time was that, well, they're both depressants, they'll just be additive. I'm going to show you that that's probably not the case with low doses of ethanol. It might be the case with very high doses of ethanol and high doses of opioid, but in the main, this is probably not the cause of death. There could be synergistic effects. There could be an effect of alcohol to reduce opioid tolerance. And obviously, I wouldn't have discussed the mechanism of opioid tolerance before this if this wasn't where we were going to go in this talk. We're going to look at alcohol reducing opioid tolerance. My collaborator, who's an epidemiologist and works in social medicine, prefers non-pharmacological explanations, and he suggests that maybe when people have come out of prison or out of a rehab center, they've got low levels of tolerance, and that just one or two drinks makes them think about going back to taking the opioid again. So we have potential pharmacological explanations, and we have a potential sociological implication. So we did the same kind of experiments, looking at respiration. In the first experiments, we chose a very low dose of ethanol, 0.3 mg per kg. And this dose doesn't do anything in naive animals to respiration, so we don't have any depression of respiration by ethanol. And animals that have received a morphine treatment for 6 days, the ethanol still doesn't do anything, so they haven't been sensitized to the effect of ethanol because of the morphine treatment. There's no evidence for any kind of synergy because, again, in untreated animals, if we give them morphine, we get this level of respiratory depression. If we give them ethanol, we get this level of respiratory depression. It's exactly equal. But if we give the ethanol, probably within 5 minutes of the morphine challenge, that's about as quickly as my PhD students can do 2 injections in a mouse, all right? So it's more or less simultaneously ethanol with the morphine challenge. Then what you observe is that ethanol reverses the tolerance that the morphine treatment has induced. So our hypothesis is that ethanol makes morphine or heroin more dangerous because even at a low dose of ethanol, tolerance is reversed. If you do the same experiments with methadone and buprenorphine, then you don't see any reversal with ethanol of the tolerance that's developed. So ethanol doesn't reverse tolerance induced by methadone, and ethanol doesn't reverse the protection that you induce with buprenorphine. So it's a fairly selective effect of ethanol against the tolerance induced by morphine. We then went back to the cellular system that we had, recording from locus coeruleus neurons. And here we've used the maximum response to morphine at 30 micromolar. Morphine being a partial agonist, then by definition, you've got 100% of the receptors activated here. And you can see this is the level of the morphine response in a normal, a slice taken from a normal animal. In an animal that's been treated with morphine, then the response to morphine has been decreased. And you can see that here. And then if you give ethanol 20 millimolar, we can now control the concentration because this is an in vitro slice preparation. Then with 20 millimolar ethanol for 10 minutes before we put the morphine in, then you can see that the tolerance has been reversed. Again, tolerance has been reversed. Now, 20 millimolar ethanol is just about the driving limit in England. So this effect that we're seeing to reverse cellular tolerance occurs with a fairly low concentration of ethanol. So we've also done the same experiments with oxycodone. I'm just not going to show you. But we think that the tolerance to these drugs is mediated by PKC. So the real question then is ethanol reversing or inhibiting protein kinase C? So there's a question mark here because Sarah Withy in my lab and a few other labs around the world have gone through lots of attempts to show that ethanol will inhibit protein kinase C. Sarah had isolated protein kinase C alpha. She changed the lipid composition of the liposomes. She changed the cofactors. And finally, she got 20% inhibition of PKC with 100 millimolar ethanol. And she came dancing down the corridor saying, it does inhibit PKC. And I said, but yes, but it's at 100 millimolar. And we see the effect at 20 millimolar. And so she went away pretty disgruntled. All right. I gave a talk on ethanol in Australia a number of years ago, and at the time Andrew Samoji said, well, you know, have you thought about acetaldehyde? And I said, well, everybody knows there's no acetaldehyde in the brain, you know. Disulfiram works peripherally, and so all the alcohol dehydrogenase is peripheral. How wrong was I? We now believe that the active ingredient is actually acetaldehyde. So Rob Hill in the lab has shown that acetaldehyde injected IP at a low dose will reverse the tolerance to respiratory depression. Alex Conabier has shown that actually the acetaldehyde doesn't inhibit the activity of protein kinase C. This is where we were all going wrong. We were all using isolated enzyme in a test tube. What acetaldehyde does is it stops the translocation of PKC from the cytoplasm to the plasma membrane, where it will then phosphorylate the receptor. And most recently, Rob's administered depenicillamine to mice, and that reduces, depenicillamine sequesters acetaldehyde, and that reduces the ethanol reversal of morphine tolerance. So ethanol does reverse morphine tolerance, but the active ingredient is most likely acetaldehyde. So, 4 or 5 years ago, I was invited down to the Bristol Drugs Project as part of the University of Bristol's outreach program, and I was talking to people going through their rehab programs, and I was telling them about all the effects of drugs on the brain. And most of these people in rehab know much more about opioid pharmacology than I ever will. And one guy said, "So why are all the heroin users in Bristol also taking pregabalin and gabapentin?" And I went, "Do they?" Okay. So we became interested in why opioid addicts were taking pregabalin and gabapentin. So a little bit of background. So this is the number of prescriptions in England in millions. And this is over the last, for 11 years up to 2015. And you can see that there's been a 10-fold increase in the number of prescriptions. That's great news if you've got shares in Pfizer. The reason for this increase is because the pregabalin and gabapentin have been used more and more for other disorders other than epilepsy, which is what they were first introduced for. They're used in the treatment of pains that are largely opioid resistant, neuropathic pains and back pains. And most recently, pregabalin is now used because it's an effective treatment for anxiety. They're also used for a number of other disorders, and gabapentin is even used to treat alcohol withdrawal. But the problem is that recently, the pregabalin and gabapentin have become drugs of abuse because at doses greater than you would probably be taking therapeutically, they induce a feeling that's a bit similar to being drunk, but you don't get nausea and vomiting, and you don't get violence. You get relaxation, enhanced sociability, euphoria, and then finally, you get dissociation and sedation. We then went into a collaboration with people at the Office of National Statistics in Newport, which gave us data for England and Wales. And what we have on this graph is the number of deaths in which the coroner's report said that there was the presence of either gabapentin or pregabalin. And you can see that there were few reports up until about 2012, and then the number has shot up. Now, there are various ways you can interpret these data. One is that it's only as good as what the coroners ask for. So that down here, there might have been a lot more deaths involving gabapentin and pregabalin, but coroners were not asking for the test to be made after death. However, I don't really care about that. What I care about is the fact that now that they are asking about it, there's a large number of deaths. In Scotland, there are more deaths. In 2016 in Scotland, there was over 200 deaths. And there they have a better reporting system. All right? Almost all blood tests at death involve a test for gabapentin or pregabalin. In the green here, what I've shown is the number of these red deaths in which an opioid was also mentioned. There are very, very few deaths in which the coroner's report says only gabapentin or only pregabalin were present. There's almost always other drugs present, and the most common ones are opioids. And in 2016, 90% of the gabapentinoid deaths, all right, the opioids were also present. The gap between here and here, all right, because this is just a proportion of these, this might just have been because they didn't test for an opioid in those cases as well. So there is this information, but you can interpret this as you like. You can interpret it that a lot of heroin users are taking gabapentin or pregabalin. They have a long half-life, and they just happen to be present when they subsequently overdose, but there's no actual interaction between gabapentin or pregabalin and the opioid, and that this is just a chance observation. So Abby Linden was a PhD student in the lab who came thinking she was going to do a little bit of in vitro work and a little bit of in vivo work, but we sent her to the Bristol Drugs Project to interview heroin users. And so she spent 2 years interviewing people at the Bristol Drugs Project Needle Exchange. These were all known opioid users. We weren't looking for a statistical analysis of a huge number of opioid users. We were just looking for a snapshot of what do the current people in Bristol who we know are active opioid users think about gabapentin and pregabalin. So she got a mixture of males and females, different ages, different lengths of use, different styles of taking the drugs, and they were all on different opioid substitutions, some on methadone, some on buprenorphine. So 21 of the 30 said that they had taken gabapentinoids. Mostly in Bristol, it's pregabalin. I gave a talk earlier this year at the International Overdose Prevention Day in Scotland and discovered there that most of the deaths are gabapentin rather than pregabalin. I think that just reflects the way the drugs are prescribed in Scotland versus England. In Scotland, the GPs are told to prescribe gabapentin because it's generic and cheap. Down in England, GPs are prescribing the more expensive drug. Most of them just bought these drugs on the street. They're all pharmaceutical grade, they're all tablets. They're obtaining them from GPs. They said that they took the drugs orally sometime prior to the heroin injection, and this is different from cocaine. In Bristol, most of the heroin users take cocaine along with heroin. They mix it up in the same solution, and they inject the two together so that they get a cocaine buzz, and then a little bit later, the heroin comes in. But for the gabapentin and pregabalin, they actually took, they didn't relate the time of taking the drug to the time that they were going to inject heroin. And you find that they take a wide range of doses. One guy was taking 5 or 6 tablets of pregabalin at a time. Some of them, others just took a relatively, well, this is quite a high dose, but not quite an enormous dose as that. They reported that it gave them a buzz, a bit of a feeling of being drunk, that with higher doses they got sedation and tranquility, which heroin addicts call gouching. And this is what they're looking for from heroin. So you can see why perhaps pregabalin and gabapentin are popular with heroin users, because they're getting an effect that's kind of similar to the long effect they get after the injection of heroin. They suggested that pregabalin would enhance the effect of heroin. Large doses, they said, could make people completely into zombies, lose control. And they all suggested that there was a risk of overdose if you combined the drugs. But if you speak to heroin users, that's not a reason to them to not take the drugs. They all consider that the risk of overdose is just a risk that they accept. Some of them suggested that it decreased the withdrawal between the heroin doses, and there was even one woman who said that it reduced the craving for heroin. And that's quite interesting because Sandy McKnight at Park Davis, when they were the people who had developing pregabalin, actually reported that pregabalin reduced self-administration of opioids in rats. So we came back to the lab. Rob Hill did these experiments. Pregabalin doesn't depress respiration on its own at this dose, either in naive mice or in mice that have been pre-treated. But if you give the pregabalin just before the morphine challenge in animals that have been pre-treated with morphine, then you get a big depression of respiration. And this is, again, the reversal of the tolerance, because the animals, if they didn't get pregabalin, didn't show any respiratory depression. So we think that pregabalin reverses tolerance and therefore will increase the danger of heroin overdose. We've shown that pregabalin will reverse tolerance induced by oxycodone. And again, we've shown, like ethanol, that pregabalin doesn't reverse methadone tolerance. Pregabalin has a long half-life, and so if people are taking this 4 or 5 hours before they inject heroin, there still will be significant pregabalin around such that the tolerance will be reversed. So we think that pregabalin is a kind of dangerous thing for heroin users to be taking. What we haven't done yet is to discover the mechanism of action of pregabalin. We think we're looking to see whether or not, like acetaldehyde, does it prevent the translocation of PKC to the plasma membrane. We believe that the effect of pregabalin that we observe is an off-target effect. It's nothing to do with its interaction with calcium channels. So almost all the pregabalin and gabapentin that's around on the street is diversion from prescriptions. So there's a great need that GPs are aware of the problems of prescribing these drugs. And Public Health England issued a prescribing advice in 2014. And in 2015 and 2016, the number of prescriptions went up. All right. You'd have been better with a chocolate Fireguard. Okay. Leslie Iverson, one of the last things he did as chair of ACMD was to recommend that pregabalin and gabapentin be made at Class C drugs, similar to the benzodiazepines. This is a very unpopular recommendation amongst GPs because they immediately throw their hands up and say, we need alternative treatments for chronic pain if we can't give out pregabalin and gabapentin. However, when I was up at the Scottish Drugs Forum, one of the peer educators told me that in his housing estate, the heroin users, they target the locum GP when they know there's a locum on. And the other thing they do is they get little old ladies to go down to the GP complaining of back pain. They just get given pregabalin or gabapentin. They come back and they buy them. The heroin addicts buy them from the little old ladies using cigarettes that they've stolen somewhere else. Just to finish, Catherine Glover is the medical director of prisons in the southwest of England. It's just purely accidental that she's in the southwest of England. Catherine and I have never met, but we do communicate by email. And she picked up in our studies through the BMA prison doctors who have an email system about papers that have come out. And she looked at the people coming into the prison who were on a prescription for pregabalin or gabapentin. And all of them had other drug abuse problems. So it wasn't that they were coming in with this prescription because they had back pain. All right. And so what they've done is they're introducing a system where there will be, everyone who comes into the prison will be told that they're going to be weaned off pregabalin and gabapentin. Those that claim they need it for their pain will be assessed by Kathy Stannard, who's a consultant pain doctor in the southwest of England. Anyone who knows Kathy Stannard will know that having to see Kathy Stannard is not going to be a pleasant experience. She's a hard-nosed lady. It's delightful, but hard-nosed. So these are just quotes from Abby's work that they've used in the publicity material that they're giving out to all the people who are coming into prison who are on these drugs. And the idea is that they'll be taken off them. So obviously, I didn't do any of the work. I have a great number of collaborators. I'd just especially like to point out my long-term collaborators, Eamon Kelly, Chris Bailey, and Bill Dewey. But there's a whole lot of other people here who've done a lot of good service to us. Thank you very much.